First thing I'll do is introduce you to a very interesting paper by Lanska from 1997, where he talks about the origins of the positional testing and conceptual developments. Really great paper. And one of the first things he talks about is how Robert Barani in 1921 described one patient with BPPV. And he did a very good job of describing what he saw, which was, you can see a strong rotary nystagmus to the right, which was the downward ear. And he also described a vertical component upwards. Now, some of you are thinking, vertical nystagmus, that's bad. Now, why am I so concerned about the fact that the nystagmus seen in a positive Dix-Hallpike test is often not described using the word vertical? Well, the reason lies in the fact that almost everyone who learns about vertigo the first time, the thing they grab onto is that vertical nystagmus is bad, that it's central. So if you see any vertical nystagmus, you've got to, rule out a central cause. When in fact, the most common nystagmus you'll see in almost any clinical scenario will be the positive Dix-Hallpike, which often will have a vertical component, especially if you have them look towards their upward ear. Kerber in this study showed emergency physicians a positive Dix-Hallpike with vertical nystagmus, and these are some selected responses he got. And these people did not believe that it was a positive Dix-Hallpike. They thought it was a central cause. It might be PCP. Obviously, these kinds of attitudes would not lead to appropriate treatment with the Epley maneuver and probably lead to inappropriate imaging and overall a poor assessment and treatment of BPPV. Finally, we get to the original paper by Dix and Hallpike, where they describe the test for BPPV, which bears their name, and also what they observed when they performed it. But first, they give Barani's description of the nystagmus he saw in his one patient with BPPV in 1921. Here's what Dix and Hallpike quoted Barani as writing. And you'll notice that the vertical aspect of the nystagmus is not included. Just to refresh your memory, here's the original quote I showed you at the beginning of this video. Here's a quote from the Lanska paper. He found this curious and felt that they must have intentionally left this out, which of course they did. They then went on to describe what they observed during their positional test, which became known as the Dix-Hallpike test. And what they observed was the nystagmus was chiefly rotatory, directed towards the downward ear. That is the same as what Barani saw and the same as what we just saw in our videos. But if you look at the highlighted part, they also said that there's generally a horizontal component, which is again directed towards the downward ear. Now, we didn't see that in the videos. That's not what Barani saw. So why did they say that? In the first article I showed you by Lanska, he described this as being the sole error of their clinical description. That, in fact, the nystagmus is not having a horizontal component, but does have that vertical or upbeat component, especially when they look towards their upward ear. So what the heck is going on here? Were Dix and Hallpike wrong? Why didn't they describe the vertical nystagmus that Barani saw? And why did they say they saw horizontal nystagmus? The first thing I'll discuss is why they didn't see or describe vertical nystagmus during their Dix-Hallpike test. The answer may lie in this paper published 4 years later by Cawthorne and Dix and Hallpike, where they include a small diagram of how to perform the Dix-Hallpike test. So in the text below the diagram, you can see that they suggest that the patient looks at the examiner's forehead, and you can see the examiner is on the side being tested, in this case the right side, and that once the patient is in the Dix-Hallpike position, you can see the little pupils on the enlarged diagram of the head, that they are looking towards the downward ear because that's where the examiner's forehead is. So I think the reason why they didn't see or describe vertical nystagmus was because the way they performed their Dix-Hallpike test did not produce vertical nystagmus, only rotational. Now the second question is, why did they say they saw horizontal nystagmus? A clue may be in Lanska's paper, where he said that you don't see horizontal nystagmus in positional vertigo except in rare cases of horizontal canal BPPV. Horizontal canal BPPV, was only described more than 30 years after the Dix-Hallpike paper in 1985 by McClure from London, Ontario, plug for Canadian content. Now, can horizontal canal produce horizontal nystagmus during a Dix-Hallpike test? Sure it can. This guy we thought had regular BPPV, but when we did the Dix-Hallpike test, testing his left ear, downward ear, we saw purely horizontal nystagmus towards his downward ear. Now, when we tested his right ear with the supine roll test, we also saw purely horizontal nystagmus, this time beating towards the right ear, which is again the downward ear. This is called geotropic horizontal canal, BPPV, and both sides produce nystagmus, which beats horizontally towards the downward ear. Now again, in Dixon-Hallpike's original paper, they described 38 cases of bilateral BPPV. Could it be that the bilateral BPPV they saw was actually horizontal canal BPPV, and they saw a lot of horizontal nystagmus, and that's why they described it as part of the component of a positive Dix-Hallpike test? But if Lanska is correct and horizontal canal BPPV is rare, that doesn't make sense. But is horizontal canal BPPV that rare? A number of recent studies would suggest it's very common. Vanni's study, which looked at undifferentiated vertigo patients presenting to an emergency department in Italy, he taught emergency physicians how to diagnose posterior and horizontal canal BPPV as well as other bedside vertigo tests. Half the patients that he saw, of the 352 patients he saw, did have BPPV, and of the BPPV patients, 39% had horizontal canal BPPV. Another Italian study looking at almost 2,700 patients presenting to vertigo clinics in Italy showed that 38% of the patients with BPPV had horizontal canal BPPV. Just so you don't think it's only Italian adults who get horizontal canal BPPV, this American study showed that in 110 pediatric patients with BPPV, 34% of them had horizontal canal BPPV. And from Korea, 1,900 patients, 31% horizontal canal BPPV, only 14% bilateral. So how does this make sense? The Korean study, which had 19 times as many patients as the Dix-Hallpike study, showed 14% bilateral BPPV, but 31% horizontal canal BPPV. Of course, they were all diagnosed by seeing horizontal nystagmus, while the Dix-Hallpike study showed 38% bilateral and 0 cases of horizontal canal, and yet they described generally a horizontal component to the nystagmus. In this hot-off-the-press study by Pollock of 2,000 patients with BPPV, less than 3% had bilateral posterior canal BPPV. And she correctly notes that it's possible to misdiagnose horizontal canal BPPV as bilateral posterior canal BPPV. And of course, this would be an even easier mistake to make 30 years before the first report of horizontal canal BPPV. One last study, this one also from Korea, where they had 62% posterior canal, 35% horizontal canal, of which about 2/3 were geotropic, where the nystagmus beats towards the ground, and about 1/3 was apogeotropic, where it beats away from the ground. That's a fairly typical ratio of geotropic to apogeotropic horizontal canal BPPV. So, given that, did Dixon-Hallpike see apogeotropic horizontal canal BPPV? In fact, they did describe 3 out of their 100 cases where the nystagmus seen was beating towards the uppermost ear. In other words, away from the ground. That doesn't occur in posterior canal BPPV, but that is exactly what happens in apogeotropic horizontal canal BPPV. So the answer to why they said there was generally a horizontal component to the nystagmus seen, and why more than 1/3 of their cases were described as being bilateral, is that they were describing the common features of geotropic and apogeotropic horizontal canal BPPV. Interestingly, Balo in this paper describes how in 1977, towards the end of his life, Hallpike at a Barani Society meeting argued that the characteristics of the nystagmus indicated that it must arise from activation of several canals rather than a single canal. So there are 4 facts from the Dix-Hallpike paper that need an explanation. Firstly, they don't describe the vertical nature of posterior canal BPPV. Secondly, they described 38% of their patients having bilateral BPPV. And thirdly, they described a generally horizontal nystagmus seen. And lastly, they described some cases of nystagmus beating towards the upward ear. There are two possibilities. First possibility is that they saw vertical nystagmus but chose not to describe it, that all their patients had posterior canal BPPV and 38% of them had bilateral BPPV, and that they never saw horizontal nystagmus but they erroneously described it anyway, and also that they never saw nystagmus beating towards the upward ear but they described it anyway. Now, I've already explained why the way they performed the Dix-Hallpike test is why they never saw vertical nystagmus and so they never reported it. Possibility 2 is my personal theory of why they wrote what they did in their paper. And we already went through item number 1, items 2, 3, and 4 are all explained by my theory that they were seeing a significant portion of horizontal canal BPPV, which would explain why they reported so many bilateral cases, why they saw a lot of horizontal nystagmus, and why they even saw cases where the nystagmus was beating towards the upward ear. If we use Occam's razor, which can be paraphrased as the theory that makes the least number of assumptions is the most likely to be true, then I think my theory is probably true. So just to summarize, my theory is that Barani had the nystagmus correctly described for his one patient who had posterior canal BPPV, and he described rotatory and vertical upwards nystagmus. While Dix and Hallpike, in their 100 cases, described the two predominant types of nystagmus seen in BPPV, which is rotatory in posterior canal and horizontal in horizontal canal BPPV. But they didn't distinguish them from being two variants of BPPV, and that's because horizontal canal wasn't described until almost 33 years later. So why should we care? Well, I think it's important to recognize that their observations weren't wrong or in error, that we can now safely remove this small stain from their otherwise spotless reputation. This only adds more validity to their hallmark study because now we know that they were describing the features of posterior canal as well as both geotropic and apogeotropic horizontal canal BPPV, albeit without a full understanding of what they were observing. Now, what does this have to do with the poor adoption of the Epley maneuver by emergency physicians, primary care physicians, and others? Well, despite the fact that the Epley maneuver was described over 25 years ago and that it works on the most common form of BPPV, which is the most common cause of vertigo, and that it has one of the lowest number needed to treat in all of medicine, and that it's safe, easy to perform in minutes, you don't need fancy equipment, and the fact that emergency physicians state that they like doing procedures, it's rarely done by emergency physicians. Now, what are the consequences when you don't recognize that vertical nystagmus is normally seen in posterior canal BPPV? It might lead you to not attempt the Epley maneuver, which is a highly effective treatment. It might lead you to over-investigate with CTs or MRIs or over-refer. And frankly, there's not enough dizzy experts in the world to treat all cases of BPPV. Primary care physicians, emergency physicians have to step up and learn how to diagnose and treat BPPV. So what's the consequences when you don't recognize that horizontal nystagmus seen during the Dix-Hallpike test is likely horizontal canal BPPV? If you mistake this for posterior canal BPPV, you might attempt the Epley maneuver, which doesn't work for it. And if you're starting to do the Epley maneuver on everybody has BPPV and a third of your cases are horizontal canal BPPV, you've now decreased the effectiveness from 80% of the Epley maneuver to less than 50%. And let's face it, a procedure that is effective in less than 50% is not a procedure I'm very interested in doing. You're going to stop doing it, you're going to say it doesn't work, and that's going to lead to over-investigation and over-referral again. So does all of this have any significance today? Yes, I think it does, because it's important that vertical nystagmus should regain its prominence in the description of a positive Dix-Hallpike. And it should be known that if you see horizontal nystagmus during a Dix-Hallpike test, this is probably horizontal canal BPPV. It is not uncommon, and it needs a different diagnostic test and a different cure. And if you can understand these facts, then you can cure more people of both posterior and horizontal canal BPPV and have improved the outcome for your patient and better satisfaction for yourself.